Okay, so indeed, my name is Philippe Conus. I'm professor of psychiatry in Lausanne, and I'm also involved in the International Early Intervention and Prevention in Mental Health Association. I say that because my talk is going to revolve a bit about early intervention. So the title, Early Intervention in Mental Health and Access to Quality Care, a political, societal and environmental issue. I'm sorry for the very long title, and I hope I will make this clear during this talk. The main idea I want to discuss or expose is actually that it's great, and we've heard a lot of fantastic developments in treatment for mental health disorders and difficulties, and this is very important, but I think it's not sufficient. That is, we can have the best treatment we want, but if we don't work at the political, societal and environmental level, the impact of these new developments is going to be limited. So I want to speak about that today. And to put a frame around that, I'm going to talk a bit about the achievements of early intervention as an introduction, and then I will read through this lens these three dimensions. So the achievements of early intervention strategies, you know, this is a bit of a caricature, but in the past, treatment was mainly taking care of chronicity. This is up to the 1980s. So there was, I guess, a lot of goodwill and benevolence in these treatments. But the approach was quite pessimistic in terms of prognosis. We thought patients would be chronic. There was high stigma, low empowerment of patients, and poor outcome, actually. No hope to help these patients recover. They would stay for a long, long time, if not ever, in hospitals or asylums. In the 90s, people, one of them is in the room, Jan Olaf Johannessen, but Pat McGorry, Max Birchwood, Merethe Nordentoft, thought we need to do better and we need to intervene a bit earlier. So that's when the idea of early intervention started. That's about end of the 80s, beginning of the 90s. The idea being to access patients earlier. So I will just explain what happened in the domain of psychosis, but it happens also in other domains now. So the idea was mainly reducing the delay, so identifying patients as soon as possible after they develop a first episode of psychosis, because we know that if we don't have specific intervention strategies, usually patients go through 2-3 years of symptoms before they get treatment, and this is not a good thing. So the idea was to reduce DUP, which is duration of untreated psychosis, and then to also, not only that, but also adapt the content of treatment. We have to propose something to these young patients, first episode psychosis, treatments that they need and that they like, and not give them treatment that would be more geared to the more chronic phase of the disorder. So there's been a lot of work to improve treatment. And one of the main challenges in this phase of the disorders is actually the disengagement. A lot of these young people have trouble accepting help. They don't think or they don't want help, don't think they need help. So one of the main elements of these early intervention strategies has been to reduce disengagement by improving accessibility of treatment. And this is for us professionals to do. It's not for the patients to access difficult treatment, but it's for us to make treatment very accessible and adapted to the way they need the treatment to be. So a lot of effort has been made also to promote engagement through strategies, knowing how to speak to patients, how to sort of help them be involved in treatment by empowerment and discussing with them. And then we can also identify patients who are at high risk, patients with forensic issues or patients who use substances, and it's important to work around this issue, and also patients who have cut ties with family. We know that family is very important for engagement, so we do a lot of effort to include families in treatment, and open dialogue is one way to do that. And with this kind of thing, in Lausanne, we have such a program. We went from 70% of disengagement in the current, in the common treatment to over 6 months to a rate of 6% of disengagement over the 3 years of the program. So if we organize the treatment and if we give strategies to patients that are adapted to the needs, it works very well. And we see the patients, they don't disengage. So this is very important that we develop that. Then there's a lot of work to do to promote recovery. So it's a long process, and it's a process that needs to involve patients. This is, I believe, psychotherapy. It's giving a new sense or finding a new balance with what you have gone through and what you have in terms of resources and difficulties. And then you need to offer integrated and adapted treatment content, so case management, psychotherapy, family approach, appropriate medication. In many cases, medication is needed, but you have to adapt the dose, not give too much. And then group treatment, supporting employment, cognitive remediation. So a lot of tools have been developed, and we know that this works much better. Actually, we know for a long time that these approaches are more efficient and they cost less. So you wonder why we don't do that everywhere, but by far, it's not implemented everywhere. Maybe we like to waste money and to have inefficient treatment. Maybe that's the cause. Mariette Nordentoff made a review paper. There was other review papers later, and she showed with this review that specialized programs are more effective in dealing with negative symptoms, more effective in reducing substance abuse, decrease use of hospitalization, improve patients and family satisfaction, and this is a very important thing as well, and they cost less. She also added that if the duration is too short, then the effect fades out in the years coming after. I would say that often it's like that, like you have a very good treatment for a while, and then you enter a bumpy road after this specialized treatment. So I would rather say, if quality of care after specialized early psychosis treatment is not good enough, these benefits are lost after a few years. But it's the same if you treat very well diabetes for 2 years and then you let people without medication, without treatment, without prevention, then the benefit you have in the first 2 years is lost also. So we have to provide good treatment at every stage of the disorder. These guys, Jan Olaf, who's back there, but also the others, thought, okay, this is good to provide good treatment for first episode. Maybe we should do a bit better, do a bit of prevention, like Erasmus proposed, prevention is better than cure. We know that. So a lot of effort has been put into indicated prevention. That is identifying patients in the phase where the first symptoms start to emerge. They don't reach the level of psychosis, but they start to emerge. We call it prodrome or at-risk mental state. And this has been now well identified to actually access the people who are at risk of developing a first episode of psychosis and to try to propose adequate treatment to them. So that's the concept of the prodromal phase or the at-risk mental state. I don't want to go into detail of that. You've heard that before. So there's attenuated symptoms, and then progressively they reach a certain level where you have a first episode of psychosis if you don't do anything. We have scales to assess that. You can train to do that. So it's become a very efficient way also to identify at-risk mental state. One of the problems is that many of these patients actually do not develop psychosis. 2/3 do not develop psychosis. 1/3 develop psychosis over 36 months, which is not too bad, but it means 2/3 don't develop psychosis. So should we stop bothering? Should we find another way? Well, actually, Paolo Fusapoli showed that these people who fulfill these criteria of at-risk mental state, it's not like they have nothing. They have impairment in functioning, reduction of quality of life, intensity of difficulties that is similar to first episode patients. So we cannot leave them. It's just the issue of do they transfer to psychosis or not, but they need support and they need help. So that's why Pat and Barnaby and many others have developed intervention, mainly psychosocial interventions for this phase of the disorder with quite good efficiency, especially against suicidal ideation and suicide, because that's one thing that these patients express in this phase where they feel that something's going wrong. It's really stressful, and so they sort of need support and psychological support mainly. There's also research in biological interventions, mainly neuroprotection, so omega-3 fatty acid. One study suggested that you can reduce the number of patients who transit psychosis, but actually there's a need for much more research to really have good ways to protect the brain and to develop, not to develop disorders. So in summary, early intervention has been a major improvement in, and has changed, I think, the way we approach psychiatric disorders. I think a lot of people had hope before, but I think it's really in the core strategies of early intervention to have hope, ambition, empowerment for patients. I think it has changed the quality and efficacy of treatment, the availability of prevention, research, family satisfaction, patient satisfaction. And we try to do the same in other disorders, such as bipolar personality and eating disorder, to really try to do prevention like we do in all other domains of medicine. The problem is that it's great, but these gains are quite fragile. I told you that if you stop this treatment, then you lose the impact if you don't have proper treatment. They're not available everywhere by far. Many elements limit their impact, and we also need new targets to really do maybe primary prevention. So we, in order to do that, and I just showed you the early psychosis domain, but it's the same in other domains. I think we need to also work at the political, societal, and climatal level if we want these strategies to work. Because if we just have them among us, among mental health professionals and patients and families, but it's not embedded in the politics, then it never works. So I'm going to talk a little bit about that. So first, the political level, we need to fight for better mental health care. We know for a long time now, it's more than 30 years, that early intervention is efficient. I showed you this picture here. That actually, it's a funny thing. It's never used that. But, So it's more efficient and less costly. And Pat McGorry, sometimes he's a bit, he loses hope or he's a bit desperate because he's been talking about that everywhere around the world, and in many places we don't have these early intervention programs. And if you have one, you get a lot of calls from other regions saying, okay, can you take care of my son because he's been at home, nobody cares for them, and can they come to your program? So it's really frustrating to see that despite it's well proven, it's not applied everywhere. Why is it so? Probably because sometimes people don't want to listen to the new ideas. They'd rather keep doing the silly thing of having square wheels instead of using the round one that we've developed. Or also, everybody wants change, but who really wants to change and makes the effort it takes to change? That's another issue. So that's also sometimes the difference. This would be great, but you don't do the effort of doing it, actually. But I think it's really an outrage that in psychiatry, we could keep treating patients with tools we know don't work, and that we could accept using strategies that have proven not to be efficient in engaging patients. And it's like, how is it possible we do that in psychiatry? Would we be allowed to do that like in cardiology, for example? If you were to put this type of cardiac valves that was used when I was studying medicine, that's a long time ago, if you were to use this kind of valve now, you probably would go to jail because we know it's dangerous, it doesn't work well, so you have to use the top and last developments in cardiac surgery. Why don't we do that in psychiatry? This is really strange. I think it's totally unfair. So how dare we? Actually, this sentence usually how dare you, but I think it's how dare we. So how do we let this happen? And how do we not engage in fighting for better treatment for all? I think part of it is stigma, actually, as you know, and I think a lot of politicians don't want to listen about, and good part of the population, and even us professionals sometimes, are stigmatizing patients. So stigma has something to do, and that's why it takes, you will have noticed I'm a fan of Pat McGorry. I spent 4 years with him, and I think he's a great person as well as a great researcher and psychiatrist, but he's fighting endlessly with the Australian government to try and promote these new approaches so they're available to all people. And Merete Nordentoft, again, it's always a bit the same people, but she's done an initiative. It took her 10 years to develop that, but she recently got 20 million increase of the budget for mental health. And she said we developed a collaboration between health authorities, authorities for social services and housing, and many stakeholders. These stakeholders being joined in a psychiatry alliance. So it's users, organizations, trade unions, scientific societies, and psychiatrists, doctors. So we have to get together to put the pressure on the government and propose plans. She said it's good to be together and to have ideas, but then you have to be practical and propose a plan. And so maybe it's an idea for ISPS as well to come up with a plan, minimum plan that we need everywhere, and fight for this plan to be accepted. So an assertive approach towards politicians and media was pivotal, and presenting a tentative budget was very influential. So I think that's the two things. We have to put pressure, but we have to have clear ideas that would be applicable concretely. If you just go and say, we need more for mental health, it's okay, well, that's great. But if we say we need more and we need this, and that, then it's a bit more convincing. You can put numbers and they can sort of get elected because they've done that. So you have to work with the narcissism of politicians. So conclusion one, we mental health professionals, but also service user, relative friends, must fight at the political level for better mental health care. I think that's a very important thing, and these associations like this one or like IEPA need to have to raise their voice to help the level of care, to improve the level of care. Second domain, and I'm going to illustrate that through a project we have in Lausanne, but it can be in different ways, but society has to change. We have closed the hospital, the big hospitals, and I think it's a good thing. We have reduced number of beds. It's a good thing, not every day, because when you run a hospital and you have no beds, it's also not a very good thing, because people need hospital. I think hospital is an important part of the system. Maybe it was too big before. We need alternatives, but sometimes patients need hospital. So we should not get rid of all the hospitals. The idea was to reduce exclusion and chronification. But I think in this change in the 60s, 70s, 80s, not much work was done to prepare society to be more open to patients. Actually, it's very nice to kick people out of hospital, but if nobody's there to accept them and to so I think there's a lot of isolation in society as well, because society has not been prepared, and many patients feel very isolated and stigmatized in cities and society. And so we work with my colleague here, Lilith Abramian and Mark Vince, who are in the audience, on this question of city and psychosis and the integration of patients. So in the past, the relationship between city and psychosis has been explored mainly by doctors and sociologists in sort of looking why there is this increased risk of developing, for example, psychosis if you have lived your childhood in cities. So we know it's true. We know it's true mainly in the Northern Hemisphere, and it's true not only for schizophrenia, but also for many other disorders like depression and anxiety, for example. We know it's a dose-dependent risk, so the more years you are raised in cities, the higher the risk to develop mental health disorders later. There's been many explanations. Social drifts, like people with mental health disorder would move to cities to access care. That's one partial explanation. But also that if you live in a city, you're more exposed to the risk factors such as infections or violence or cannabis use or things like that. So this is some of the explanations. But if you control for the effect of these elements, you still have an increased risk if you have lived in cities. So people refer to it as being the urban stress or the stress of city, but actually we don't really know what is the stress of city. It's all of that. It's the noise, the complexity, the pollution probably. There's some biological elements as well. The look of others, like being watched by others, and the density of people and complexity of relationships. We were astonished to see that hardly any research was done with patients, actually asking patients, how do you feel in the city? There was nothing about that. So we started with a study looking at the city from the eyes of the patients. We did that with geographers. So the one in the middle is Ola Söderström, who's the brother of Dag Söderström, and Zoe Kodelupi, these two geographers and 4 psychiatrists. This was the balance we needed to sort of keep track of what they were saying, because they speak complex languages sometimes. And what we did was to do walk-alongs with patients and explore with them, by filming them, discussing, taking notes, photos and all that, and then going back to the films and discussing with them, exploring how the city is stressful for patients. Basically, this was the idea. And we could, on this basis, identify factors of stress and strategies that patients use to face this stress. So the stress is linked to density of buildings, an obstacle to mobility, sensory overload, so too many signals of noise and lights and people coming. And if you have some degree of cognitive disorder, it's sometimes hard to process, and this sort of creates some anxiety. And also the risk of social interactions, meeting people you know and meeting people also you don't know, and so it's complex. And patients try to face this using strategies, either programming very carefully where they're going to go through the city, avoiding some places, and so it's a complex thing just to go to buy something in the city. It's a complex effort for many patients. Also, they try to put headphones to isolate themselves, or they create atmospheres of comfort, as we call them, going places they can sort of go away easily, or taking someone along that would make them feel safer. We also could measure that close to 2/3 of patients actually have a diminished access to city. Some never go to the city. They find ways to get food brought to them at home, and they never go out of their home. Or 50% control it very much and go as little as possible in the city. So we felt actually city generates a stress and leads many patients to avoid it, and we called it city avoidance. And even if city is stressful, it's also a place where you can access enrichment, culture, meeting people, and get treatment. So we felt this is a deprivation of resources, decreased access to care, and so an injustice, an hindrance to recovery. So we, on this basis, we developed a new project, and we think we can do something about it. First, we thought together among doctors, because doctors tend to try and help fix patients. And so our idea was urban remediation, which was actually first to measure with patients. We thought, okay, we could go with them and walk along and say, okay, this is stressful to you, this is not, this is, and then we have a list of things, and then you try to help patients face that. Do CBT therapy, do training for interactions, whatever, you try to define ways. This is all nice, but luckily we were still in connection with Ola Söderström, this geographer. Said, okay, that's very nice to help patients adapt to stress, but what about asking the city to change instead of always patients having to adapt to the milieu? And actually, why would the city not be adapted to the needs of people who've got mental health disorders, for example? And by the way, if patients are sensitive to some elements, we are also exposed to this stress, maybe unknowingly, but it also has an impact on us. And if life in city was more agreeable, it would not be bad for people who don't yet have mental health disorders. So the idea now is to actually identify stress factors, but develop strategies to reduce that, and then to involve the city to change that, and to sort of, like we did for people who've got difficulties, physical difficulties, we have, we help them, so I don't know how to say that in English, but sort of things to go up the stairs and things. But we don't do anything for patients who've got difficulties, people who've got difficulties in mental health. So we involve many partners. We have the research team here. We have peer practitioners. We have patients involved in the project. We have cultural actors. We also have the city authorities who are very much involved with us and interested in making of Lausanne a mental health friendly city. And then we've got local cafes. We think about creating a brand of cafes or restaurants who are mental health friendly, where people know that the people who run these places would be sensitive and to potential difficulties, and know that some people have trouble and they would be inclined to help them, for example. And also we need to do that in the general population, basically. We need to explain people that some people have difficulties, but it's not because of that they should not be able to live in a city or to live in society. So maybe I don't want to take too much time to speak about that, but we have a living lab, so it's a group of people from the city, patients, professionals, a big group of about 25 people, and we have designed the first stage of the study, which was mapping the city, so going through in an organized way through the city, capturing stress and respite and all that, and what would be good and what is not good. And then we are at the stage 3 where we try to identify strategies. We have this meeting next week or the week after with the panel. We have many ideas of what we could do, but we want to have practical things we can implement to facilitate life in the city for patients, basically. And then if we implement this in a part of the city and then measure if it has an impact, and if it does, then we want to generalize this to Lausanne and to the world, which is the plan we have. So we count on you. So conclusion 2, we, mental health professionals, but also service users, relative friends, politicians, artists, entire population must adapt cities and society to the needs of patients and to the needs of all humans, as I said, because if it's good for the patients, it's going to be good for all of the ones who don't have yet or never will have mental health difficulties. Okay, so I talked about the political level where we have to be active, the societal level, and then third point, the environmental level. And that's where I start to speak about climate change. Actually, we left Erasmus a bit frustrated here because we do indicated prevention, but this is not primary prevention, it's not yet prevention. So the idea would be to try to prevent disorders. So we have identified risk factors for mental health disorders. Some are accessible to change. I think obstetric complication, infection, cannabis use before age 15, maybe it's not that easy. Some are more challenging, like genetics we know plays a role. It's a bit hard to change genetics. Despite what David Vandenberg said the other day, I think it's a big challenge to prevent trauma in child. I know he said we probably should, if we support family, if we help families and all that, but it's a tricky thing to have an impact on that. Migration also is a key, but it's really hard to prevent migration and traumatic migration, unfortunately. So there's a lot of domains where prevention is difficult to tackle, even if we have identified some targets. So maybe what we could do is to prevent the emergence of new risk factors, I would say. If we cannot change these ones, let's not create new ones, and let's not create new patients. And that's where the issue of climate change comes into play. Is climate change a risk for mental health? And I will try and convince you that it actually is. We know that climate has changed in the past. We know, but if you look at the curve, the red curve is the change of concentration of CO2 in the atmosphere, and blue, the mean temperature. If you see that from year 1000 to year 1850, it didn't change much, quite flat. And then in the last 100 years, it sort of exploded, you know, like, and it definitely is linked with the accumulation of CO2 in the atmosphere. I'm not a scientist in this domain, but I think the elements we hear day after day are quite convincing that the climate is changing a lot because of the action of humans. So we could probably do something to go the other way around, even if it's quite complicated as well. So the impact, you've read that. This is from The Guardian the other day. Up to 1.5, that's very close to where we are. Intensification of storms, of heat waves, and melting of permafrost, which will free up viruses and disease we don't know about that can spread out around the world, to say the least. If we go above, then the risk of brutal heat waves multiplied by 200, risk of flood multiplied by 2, and it's quite high. We see every other month there's a flood somewhere, which was not the case before. And if we go even a bit more above, 2 billion people would be pushed outside of climate niche where they have lived for more than 10,000 years. In some places, simply not possible to live anymore in some places of Africa because there's no water, so these people have to move, and we don't want to accept them, but they have to move, and that's because of human actions, so we have to do something about that. If we go up to 3 degrees, then it's going to touch us a bit harder, like New York, Rio, Miami being flooded with the rise of sea levels. And above 3 degrees, we don't produce enough food, and so the prices go up, and then the selection of the ones who have access to food and the ones who don't, and so food and water shortage, broken supply chains, refugees by the millions. So we see that there's impact on nature, resources, societal cohesiveness. That's also a very important point. And mental health is sort of easy to keep when there's social cohesiveness. When there's tensions and wars, it's much harder to sort of do prevention and look at the more fragile. Some people are more exposed than others. The at-risk regions, the native community usually, because they live very dependently on nature, aged people, children, women, poor people, and people with illness. Just to show you that during the heat waves in the US, actually it's been shown that people with schizophrenia had a risk increased, multiplied by 3 of dying during heat waves compared to controlled population. So the patients we are dealing with, if we are professionals, are people who are usually have poor access to sort of prevention strategies to face heat waves, and they are the ones who pay the cost very much. So has there been a demonstration of a link between climate change and mental health? I'm aware of time and I don't want to go into all the details of these interesting studies. There's many others, but basically it's a study where they coupled the meteorological and climate data with the data of prevalence of mental health disorders in many regions. So 2 million randomly sampled US residents, and they did 2 waves, 2002, 2012. Basically, what they showed is that the rise in average temperature and exposure to natural disasters is linked with an increase in prevalence of mental health disorder. Trust me on that. I mean, there's many studies showing that. And if you don't trust me, then don't trust me, but you should trust me. But like just to give a number, the rise of 1 degree of average temperature was linked to a 2% increase in prevalence of mental health. So it means if you have, on average in populations, usually it's between 12 and 15% of people who've got mental health issues, you go from 15 to 17% of prevalence, which means huge numbers. Like in the States, this increase equals to 8 million more people with mental health issues. So it's not just like a few, it's huge amount of people who would have mental health issue. To simplify a bit the impact of climate change on mental health, the first impact is direct impact during natural disasters, and we know that there's 40 times more impact on mental health than there is on physical health. It's like despair of having lost your relatives, having lost your way of living, have you lost all your belongings, and being, lost in the middle of the water, and so it's really a terrible situation. We know it has a strong impact, creating PTSD, depression, and suicide. There's secondly, the more gradual impact. It's mainly farmers or insular populations where they see the sea level rising very slowly, but eating into their mental balance somehow. And so it's loss of income and identity, because our identity is in our head, but it's also in the place we live. It's connected to the way we live and the way it looks. So it induces depression, anxiety, suicide. And then there's the indirect impact, which is the third one, and that we speak a lot about in rich countries, because we mainly don't have the other ones. And it's solastalgia. Solastalgia is this feeling of having lost your environment the way it was, and lost a part of your identity. Like a Swiss farmer in the Alps sees the Alps like green things, and you've got the cars and all that, and the water flooding and the glaciers on top and all this. You've got this representation of your life, and then there's no more glacier, and then it's dry, and you don't have any cows. So your surrounding change, and you've got the nostalgia of this ID and identity of yourself. Eco-anxiety is more talked about. It's all the emotions linked to the feeling of fatality in the face of climate change. So it's mainly fear, sadness, and anger. And the main cause is that governments don't do anything. They speak a lot about it, don't do anything. And so there's been this study, you probably heard of it, what young people think about the climate, and 84% are worried. 10,000 young people, 16 to 25, in many countries. So it's not just in the US or in the UK, it's really in many countries. 84% worried about the state of the planet, 59% very worried, more than 50% feeling anxious or having symptoms of anxiety facing climate change, and close to 40% thinking they will not have children because they don't want to put children in this world. We did the same study in a group of students in Lausanne. We found the same numbers, except a bit higher, because it's known that usually students are a bit more concerned by these issues. So eco-anxiety, is it a pathology or is it a normal reaction? Is the young gentleman on the right side of the screen in the right ideas, or is this young lady a bit anxious and needs treatment? Actually, it's a normal reaction. The impact of this reaction can be a disorder, because if you have anxiety that paralyzes you or makes you depressed, then you might need support treatment. But then it's not a pathology to think that we face the wall. So there's advices. I won't go into detail, but there's plenty of strategies. The main thing is it's good to be conscious of that. It's not good to spend all your time reading bad news and this, because it takes away your energy. And then, so it's good to get together and to think about actions, but not like drown into all the information, because you could spend 24 hours a day reading bad news about climate. So it's good to know, but then after 1 hour, you know, and you do something else. You do also good things for you, because we need people who are strong to face these type of issues. And you can become active. So as individuals, we know we can choose different ways to travel, for example. We can also choose foods that have a lesser impact on CO2. We can act as citizens, either voting, if you live in a country where it's done, or join political groups, or vote for people who have the good ideas regarding environment. And then we can act as professionals, I think. We have a voice to raise, and there is many groups around the world of doctors who say, okay, we are not politicians, but we are doctors. We know this has an impact on mental health and physical health, and there's a lot of actions being done. And I think all of us in this place who are mental health professionals, we should raise the awareness of politicians that it will also have an impact in this domain. And they can believe us because we are professionals in this domain. So it's urgent that physicians and scientists become actively involved in alerting political authorities about the impact that inaction in this area could have on the health of our population. And they maybe listen to mental health professionals. And if they don't listen to mental health professionals and deny it, they need professionals in mental health too. It's a little twist. So we need to be active against climate change. We did an action at IPA. Maybe ISPS wants to join or to do as well. We need science, not silence. And respect existence or expect resistance. I think they find fantastic sentences in these demonstrations, young people. So conclusion 3, we mental health professionals, service users, relatives, friends, politicians, artists, the entire population must fight against climate change in order to promote mental health. That's the third point I wanted to make. So in conclusion, early intervention and development of new treatment have improved outcome and quality of care very much. And many of the presentations here were demonstrating innovative approaches, and this is great for patients. But the gains are fragile and the benefits for patients are limited by various factors. And we need also to be active at 3 different levels, at the level of politics, society, and climate change. And I think mental health professionals, but also service users, family, relatives, and the general population are in a key position, and we should not think we cannot do anything about it. I think we are in a key position to act and to greatly contribute to the improvement of well-being of patients and of society as a whole, because what is good for patients is going to be good for all the other ones who are lucky enough not to have mental health disorders. So, thanks for your attention.